And on behalf of CME Outfitters, I would like to thank you for joining us for this three-part CMEO briefcase series titled Best Practices for Applying Recent Clinical Trial Data and Individualized Treatment to Fight EDS and OSA, a three-part briefcase series. Today's briefcase is titled Plugging Recent Clinical Trial Data into Treatment Decisions, a Fundamental Formula. Today's program is supported by an educational grant from Jazz Pharmaceuticals. I am president of Bogan Sleep Consultants, as well as an associate clinical professor at both the University of South Carolina School of Medicine in Columbia, South Carolina, and also the Medical University of South Carolina in Charleston, South Carolina. Joining me today is my great pleasure to welcome Dr. Russell Rosenberg, the Chief Science Officer and CEO of NeuroTrials Research Incorporated in Atlanta, Georgia. Welcome, Russell.
Thank you, and thank you for inviting me. I'm really pleased to be a part of this program.
Yeah, excellent. Well, to frame the discussion today, let me review our learning objective. Our goal is that after this CMEO briefcase, you will be able to apply data from recent clinical trials to optimize treatment decision-making. Let's meet Barry. He's a 36-year-old male with a history of obstructive sleep apnea, and he has sort of what you would expect based on, you'll meet Barry. He looks as though he might have sleep apnea. And in fact, when he had his sleep study performed, he had moderate obstructive apnea with an AHI of 26 episodes per hour and an O2 level nadir of 79%. He had an Epworth score of 17 on presentation, and he had symptoms of loud snoring, multiple awakenings, frequent nocturia, non-restorative sleep with residual daytime sleepiness, which he self-treated on occasion, which we'll get into more. He remains on his Cpap and is using an auto mode at a pressure set between 5 and 12 centimeters, and a download shows 96% adherence with an AHI of 2.2 and an average use of 5.5 hours per night. His Epworth score now on follow-up, after he's been on it for a meaningful period of time, is 15. He did have a quality of life measurement performed, which we call the FOSQ, which is 16. And on exam, his Mallampati score is 4. He works as a service technician and is impacted by fatigue and difficulty staying awake in meetings, occasionally missing work, and his workplace performance has not been as outstanding. He has had a history of alcohol misuse and frequent use of cannabinoids, which he has used to sort of self-treat some of his anxiety and some of his depression. He has borderline hypertension, not requiring therapy at this time. He is obese. He has a body mass index of 32. And as I said, he's had mild and moderate depression, which has responded to therapy, but he obviously is discussing his fatigue and sleepiness. He does consume a lot of energy drinks and caffeinated beverages to maintain reasonable alertness throughout the day and combat his fatigue. And he consumes a couple of beers in the evenings and currently is taking an escitalopram, an SSRI, which has been successful in treating his depression. So let's meet Barry and hear his history. Well, good morning, Barry. How are you doing today? How are things going?
Hey, Dr. Bogan. Not as well as I want to be.
What's going on? Tell me about it.
Man, I just can't shake this fatigue. I mean, I'm tired. I'm tired all the time, and every day it's a constant battle to keep my eyes open. You know, this can't be normal.
Yeah. How does that affect you? I mean, are you actually?
I spend half my paycheck on energy drinks and coffee. I need at least 4 energy drinks and 3 16-ounce cups of coffee just to get through a 9-hour workday.
Huh.
I mean, and yeah, I still smoke. No, Doc, I've fallen asleep. I've fallen asleep during meetings You know,
Mhm.
and worse, I fell asleep in a customer's house. You know, I could have lost my job because of that.
Sure. No, I understand. So it does sound as if you're excessively sleepy. Are you getting enough sleep at night or going to bed at the right time and getting up and getting enough sleep?
It, it, I don't know. You know, I don't think I think that, no, no, I don't think I am, because I'm always tired.
Yeah, no, I get, but but the main thing obviously is to get enough sleep. So it sounds from based on your download from your CPAP device that you're getting enough hours as we look at that. And in general, I mean, we'd like for you to get a good 7.5 hours of sleep from based on total sleep time because that helps with sleepiness. But there are some individuals who have residual daytime sleepiness despite adequate intake. And certainly that can be caused by major depression. It sounds like you're not really depressed.
Well, if that's your nice way, Doc, of asking me about my depression, you know, how can I not be depressed? I'm tired all the time.
No, I got you. No, I
And,
got you.
and yeah, you know, I do still smoke some weed to help me come down from my day.
Mhm.
But I did cut back on my alcohol at night. But, you know, Doc, you don't understand. I feel like I'm spiraling.
No,
You know,
I
I,
do understand.
I
No.
fight to stay awake. I, I fight to stay alert.
Mhm.
And, you know, I, I, I fight to stay here.
Right. Well, we have two things. One is your CPAP adherence data. The CPAP tells us how long you're using the device, and actually has a flow sensor in it that looks at the velocity of flow of air, and it measures how well you're breathing, how deep you're breathing, even sort of how fast you're breathing, and it gives me that data. And your CPAP is working. Without CPAP, the upper airway collapses, you hold your breath, the oxygen drops, it fragments sleep. And so the continuity of sleep is not good. So that can certainly make you tired. But with the CPAP, that seems to be corrected. But what we do know is that there's a subgroup of individuals, despite adequate therapy, that still have impairment the next day. We're not really sure why, but sometimes we believe the fragmented sleep or the low oxygen levels may affect neuronal firing. So the neurons in your brain, when they're supposed to be awake, they slow down. They don't communicate as fast. And that translates into being excessively sleepy. And when we look at your Epworth score, your sleepy score, it's still high. It came down after you use CPAP, but it's still abnormal. So we know there are some individuals who still have residual daytime sleepiness despite proper use of the CPAP. Now, there's no substitute for adequate length of time on CPAP, and we always encourage that. But the device is counting your breaths, and your breaths, your events per hour are still pretty good. So you meet one of the folks that meet the criteria for one of the individuals that probably should have therapeutic intervention. We probably should give you a medicine.
Really, for real, Dr. Bogan, another drug for me. You know, I've had some issues there.
Right. Well, I think we have medicines that are approved by the FDA. These are weight-promoting medications. They have very low abuse potential. And we have several different medications available, actually 3 of them that have been approved by the FDA. And those medications will actually improve speed of processing. So if you respond properly, you'll notice, wow, my brain is working better. I'm not as sleepy. I'm not as tired. You can think and you can remember better. May even have an effect on mood because obviously people who are sleepy are irritable and have low motivation and can have mood changes. So we can initiate that particular therapy. What do you think?
You know, as long as you're not creating more problems for me. I mean,
No, I understand. Well,
you know, I have enough of those already.
Well, I understand completely. Well, the science tells us that these medicines approved by the FDA have very low abuse potential. So we don't consider them habit forming. You don't actually have to take them every day, but it's okay to take them every day because on the days you don't take them, the brain will be slower. There's no withdrawal. So when you stop the medication, there's no withdrawal syndrome the way you have with other medications of abuse. So I think we have some really safe alternatives, and we can certainly explore those.
Okay, well, I just need something that can help me now.
Yeah.
You know, I need to get back to whatever my normal is.
Yeah. Well, I understand, and you're not alone. This is not an uncommon occurrence. In fact, depends on who you look at and how you measure it, but it may be up to 30% of patients who have sleep apnea who still have these symptoms. They're better, but they can be better with these wakefulness promoting medications. Let's give it a try.
Okay. I'm all in, Doc.
Very good. So Russell Barry has a lot going on. In addition to obstructive sleep apnea, he's obese with borderline hypertension. He's taken an antidepressant, and equally important, his sleepiness and fatigue are impacting his productivity. What do you think would be a reasonable treatment goal for Barry?
Well, before I talk about the treatment goal, let me just go back over his history just a bit. A couple things really stand out to me. And he may be doing himself more harm than good with regards to the energy drinks, the use of cannabis, and alcohol intake. And so there are some sleep hygiene issues that are in play, I think, here. But one thing that does stand out, I think many of us could be satisfied with 5.5 hours of sleep, but for somebody that is complaining of chronic sleepiness and fatigue, what I'd like to know from the download, if it's possible, is, that's an average time. So I'm just wondering if there are nights that are more or less than that, and it averages out to 5. I'd like to really know more about the frequency of nights in which he is getting, say, 7 hours of sleep, and does he feel better on those days. So there are some, like you said, it's a complex case, but not so unusual from those that you and others see in the clinic. But with regards to a treatment goal, this is a gentleman that seems to have an impact, has had an impact, that is, on daytime functioning and maybe the mood and so forth. So I think the thing to do at this point, or treatment goal, would be to try to stabilize his excessive sleepiness and increase his functionality, and hopefully that would improve mood and anxiety as well. He in the video seems a lot more anxious than he does depressed. He's sort of exasperated by this, like many patients are. They feel like they've done everything they can to deal with the situation on their own. So I think clearly there are options, as you discussed with him, and maybe some of those would be worth trying to see if we can improve his daytime alertness, get the Epworth score down to a more reasonable level, and to improve his functionality.
Yeah, I think that, as you said, there are several things. Obviously, cognitive therapy, teaching him about circadian rhythm and entrainment and good sleep characteristics, and understanding what the alcohol does and maybe the cannabinoids are doing. And so there clearly are a lot of opportunities. We can get him up over north of 7 hours. That would be awesome as well. And I like your comment about looking at the variation from night to night, even on the weekends. How do you do on the weekends compared to the work week, and et cetera. But what we also know is that a number of individuals with obstructive sleep apnea have comorbid depression. And what we also know is that in patients with refractory depression, many of those individuals have untreated sleep apnea until their depression gets better. So they do feed off of each other. And of course, sleepy people are tired and irritable and have mood changes as well. So those are all very important points. And of course, when we treat our patients, we want to reduce or eliminate the obstructive apnea, but we also want them to feel better. And some of the patients do have residual sleepiness, and I think we certainly want to address that. So when we see a lot of these patients with excessive sleepiness, and depends on the cohort, as you well know, 20%, 30%, depends on how long they use it, et cetera. We do have some treatments available to us. Do you want to talk about those?
Sure, and sort of the theme of this particular segment or program is about some of the clinical trials that both we have done and you have done in recent years, looking at this issue of residual sleepiness in obstructive sleep apnea patients. And I guess the most recent drug that's really, it's been around for a few years, but it is solriamfetol, but also armodafinil and modafinil have been FDA approved for use in OSA patients who have residual sleepiness or have some troubles with alertness during the daytime. So there's substantial data set on these three options for patients, and they all have sort of unique characteristics with regards to half-life and their ability to improve subjective and objective testing. So we could certainly talk more about that if you like.
Yeah, I think these three drugs are been well studied by the FDA. They're scheduled for, and obviously anyone has a history of drug abuse. We monitor those individuals in terms of their CNS response and efficacy of response and avoiding abuse. But typically, we've not seen withdrawal or tolerance in these individuals or rebound. So these drugs seem to be low drugs of abuse based on the clinical trials. And since he has had a history of maybe some alcohol and cannabinoid use, they represent a pretty good option for us that I would consider, at least from a safety perspective. Do you want to differentiate these in any way? I know that solriamfetol is excreted in the kidneys and modafinil in the liver. Does that make a difference?
Well, it does to some degree. I think that there are various adverse effects that are pertinent to the what I'll call the modafinils, both modafinil and armodafinil. I think that we could talk about the other indications that these are used for, but really in terms of safety profile and adverse effects, they're all somewhat similar. The issues with regards to solriamfetol that we saw in our clinical trials was a pretty impressive effect size with regards to improvements on the maintenance of wakefulness test, which is an objective measure of daytime alertness or ability to remain alert in a non-stimulating situation. But these drugs do have their adverse effects, and I think that with regards to the modafinils, there's the issue of potential allergic reactions or rash that may appear, and if so, then those patients need to be examined quite quickly and to make sure this isn't a Stevens-Johnson's type of phenomena that's occurring. Have not seen that really in solriamfetol. But I think what's positive about this particular patient of yours is that he doesn't have a history of abuse of stimulants. Mm-hmm. And even though these three drugs have not been proven to be problematic with regards to abuse potential, I feel better with these three options, given that he hasn't had a problem with stimulant abuse in the past.
Yeah, I would agree. And, and teaching about rebound from caffeine too. I mean, and the energy drinks, though you can get rebound with those. You don't get rebound with the wakefulness promoting meds, but yeah, and solriamfetol being excreted in the kidneys and not inducing the CYP enzymes, we don't worry about the oral contraceptives in females, not so much. It's not so important in Barry, but that is a differentiating point on the solriamfetol compared to modafinil or armodafinil. It certainly is there. So you mentioned that modafinil, armodafinil, and solriamfetol are FDA-approved treatments for EDS and OSA. Do you consider them equally effective, or I know you talked about effect size.
Well, in terms of head-to-head studies, we really haven't had the opportunity to look at these in head-to-head studies.
Mhm.
So, a lot of us who see these patients or utilize these drugs in research find that, it's based on sort of more anecdotal evidence of one being more useful than the other. But I will say that we've seen a lot more patients respond to solriamfetol in a very positive way than the modafinils, and then again have not had the issue with regards to the warning of rash in the solriamfetol. So I think it has some benefits to be considered in patients, but in terms of which one of these is sort of, if I had to pick the best of these, I probably would not do that with you here today, Rick. I would probably say that when I looked at
completely
the
agree. Now, that was a loaded question. I completely agree. I mean, everyone's different. Each one responds to the others, and again, different cohorts. I mean, there are no comparative studies. The only thing was in the clinical trials, as you pointed out, the effect size. When you looked at the Epworth and the NWT and the solriamfetol trial, there was a big signal, but it wasn't the same cohort. So you have to be careful with that. But I think the point is, as you mentioned, that when you look at these parameters, objective and subjective parameters, blinded in a placebo-controlled trial, they demonstrated efficacy in this population. And so it's fair in our patients who have sleep apnea and residual sleepiness that we ought to recognize it and consider treatment. Would you disagree?
No, I've got to say that I'm 100% with you that they need to get treatment. I think that this is an often overlooked problem in this patient population. I think that primary care physicians are beginning to understand this a little bit better, and even there's some room for board certified sleep specialists to be on the lookout better for these patients. So I think that unfortunately, there's a subset of patients that once they're on Cpap, they are not maybe completely dismissed from a service, but it's assumed that they are as good as they're going to get. And that's unfortunate because, unless the clinician is vigilant and really drills down on the issues related to sleepiness and functionality, then they're going to miss this sort of problem.
Yeah, I completely agree. I mean, the patients come to us because they feel bad, and obviously they don't want to get sick or die. And so oftentimes we focus on the AHI and the nadir O2 sat and ODI, et cetera, and adherence and hours of use. But it's important to recognize that a cohort does have this problem. This, I guess, Bronnebaum study reported that 50% of patients with obstructive sleep apnea related EDS may not respond to armodafinil. And so relative to solriamfetol, is there a difference in its efficacy depending on OSA adherence? That's kind of a tough question to ask because of the lack of comparative studies. And I know, no med works in everyone, but do you have any comments on that?
Well, with regards to the question about utilization and adherence to Cpap, we know that in the solriamfetol trials, patients, there wasn't much difference in outcome with regards to adherence versus non-adherence in those patients. And the other thing that was certainly of concern for many of us in this trial was whether patients who were on solriamfetol might reduce their usage of Cpap because they felt better, but that was not the case. So the subjects and patients in the solriamfetol trials really did maintain their adherence levels, and it was irregardless of of when they came into the trial, just how adherent or non-adherent that they were.
Yeah, I think that's interesting because the FDA actually wanted to look at safety and efficacy in people who weren't wearing CPAP. And of course, I mean, we should treat obstructive apnea because solriamfetol does not treat sleep apnea, but it did show efficacy and safety in that subgroup. And I think that's the first study that I've seen. But of course, modafinil, armodafinil worked well too. And in the studies, when we looked at MWT and Epworth scores and patient global impression blinded, I mean, we saw some signals there. But it was interesting to see in untreated patients that there was a signal there, at least an efficacy signal. So I agree. So clearly,
the armodafinil trials and the modafinil trials, patients had to be compliant according to Medicare guidelines.
Yeah, and then
or CMS guidelines.
Yeah, and they didn't decrease utilization as a group. There
Right.
was no decrease in utilization of the CPAP, which is really important for the patients to understand.
Right.
Absolutely, yeah. I think in my practice, probably my response rate is then subjective, but it's just an estimate. Is probably 70% of the patients will respond to armodafinil, modafinil, but not all of them respond. And so it's nice to have another molecule out there that we can potentially use. Everyone's different, you know. So we really do have to personalize treatment selection to help patients achieve the most ideal outcomes. And with patients like Barry, who have multiple comorbidities and other behavioral characteristics, what are your key considerations that you think about when you decide about treatment?
Well, besides some of the things we've spoken already about, improving their overall sleep time and sleep hygiene issues and so forth, also considering which medications they're already taking that might be problematic with regards to these. There aren't a lot of drugs that interact with the modafinils or solriamfetol, but we would certainly want to be considerate of what other medications they might be taking.
Mm-hmm.
And the degree of, I think in some sense, and I'm not sure that this is data-based, but this is for the patients who are really very sleepy and having the most difficult time, I think solriamfetol is given what we've seen in the MWTs and the Epworth sleepiness scales and so forth, is a really good option. But a lot of these decisions these days, as you well know, Rick, probably better than I do, is often made on insurance reasons and what they have to try initially to get a certain medication or to try a certain medication. But I will say one point of in our clinic and practice that I see has been a positive is that solriamfetol is available for patients to try, take home a sample, and then they can give feedback right away. Whereas it's a little more difficult, they have to get a prescription for armodafinil or modafinil. So in that sense, I think, and that's just sort of a practice issue, is that, that this particular drug is being sampled versus the others, which are older and not being sampled.
Understood. Yeah, I think the take-home message for me is everyone's different and different people respond to different meds. And, remember modafinil, armodafinil do induce CYP enzymes some, mildly, and solriamfetol is, through the kidneys. So those are different. But as you said, these are CNS active drugs. So it's important for us to follow the patients for efficacy and safety, side effects. And, they're always outliers. So we're activating the brain. So could we get some brain side effects? And so we do want to monitor our patients. And as a result, we monitor them sometimes with patient-reported outcomes. I know in my clinic, I use patient-reported outcome measures when they come back. So I get the download, but also measure the Epworth and the FOSQ and perhaps the PHQ-9 to see how their mood is doing. Do you think that's reasonable, or do you recommend that, or what do you think?
I think it depends on what sort of practice. In a sleep medicine practice, I think it's well worth doing, and because it's really more than just the sleepiness. I mean, we're not just treating sleepiness. I mean, sleepiness has a whole set of behaviors that it affects and alertness affects. So I think the idea like the short form FOSQ and certainly other short measures like the Epworth Sleepiness Scale can be used in a serial fashion to really track the patient's progress or lack thereof and make decisions about medication increases or changes. Certainly, I think that's important. I think one thing, and this is no surprise to you, that, and I'm sure you do this all the time, and one of the questions I think clinicians can think about asking in terms of functionality, if they're not keen or don't have the time for a FOSQ, is just asking the patient, straight out, what is it that you can't do that you want to do?
Mm-hmm.
And you get answers like, I want to stay awake in every meeting I go to, or I don't want to have to pull over. I want to be able to drive home without having to pull over. So those are things that, if you really can change those, and Epworth is quite good, certainly, I think, as a measure. But if you can have a few, ask them that open-ended question and find out what it is they'd like to do that they can't do because of their sleepiness, then that gives you a sort of an anchor of where to go and what to track for them.
No, that's well said. I like the idea of the open-ended question. How is the sleepiness affecting you? And that's one way to do that, because you can use that as a marker,
Absolutely.
For a response. And so, how are you doing in your meetings, or how are you doing with your drive to work or drive home, or with your family when you get in the evenings, or how is the sleepiness affecting your mood or executive function? I mean, everyone is different, and obviously the patient-reported outcome measures give us, a number, and or help us quantify it to some extent. But I think that's a great idea. Well, we're coming close to the end here. Anything we forgot or we should comment on, or any last thoughts? Or
well, I think it's really important, what we've talked about today, and I think is important for clinicians to understand is this, and you mentioned this straight off at the beginning, and that is, this is not an uncommon phenomenon. Sleep apnea patients, even well treated on Cpap, can remain hypersomnolent or can have hypersomnolence. So I think that's something for all clinicians to keep in mind, and that not to just assume that because a patient is using their Cpap device for 7 hours a night, most nights of the week, that they're perfectly fine, that they shouldn't have any issues with regards to sleepiness. And it also helps, I think, clinicians keep in mind that there could be other comorbid sleep disorders in play, even narcolepsy, but others that could be disturbing sleep. And this fellow that was your patient today, I think that he needs to back down on the caffeine use. He needs to which could be affecting his nighttime sleep. He needs to be more mindful about, when is he using cannabis? Is it only for nighttime for sleep, or is it during the daytime as well? I think there are a few things there that not everybody finds cannabis useful for sleep, and they may actually be more alerting in some patients. So, and to use these questionnaires like you use in your practice, the FOSQ and BSS and PHQ-9, I think these provide a lot of information about patients' functioning, and I think that's what we need to focus on.
Yeah, we got a lot of work to do on the cognitive therapy. I think that's really important. And again, the more the patients understand, the more they can tell us. And it's been, one parting comment from me is, remember, sleepiness is not always the complaint. It's not always sleepiness. It can be fatigue or mood changes or other complaints, executive function, attention, that we have to remember. And unless we ask about the sleepiness, they don't always tell us. So anyway, thank you for a great discussion regarding obstructive sleep apnea, and the excessive daytime sleepiness can really be a challenge to manage. But hopefully we have provided our audience with some key tools to help their patients reach and maintain optimal outcomes. So let's summarize our discussion with our SMART goals, which are specific, measurable, attainable, relevant, and timely. That is, what I hope that you will take from this presentation to apply to your practice is develop personalized, effective strategies to reduce the burden of excessive daytime sleepiness in patients with obstructive sleep apnea, apply data from recent clinical trials to optimize treatment decision-making in patients with obstructive sleep apnea, whether adherent or not to Cpap, consider medical comorbidities and drug interactions when making treatment decisions, and standardize and personalize patient follow-up, including the use of standardized scales such as the Epworth score and the FOSQ. So today's CMEO briefcase is part 3 of a 3-part series of case-based activities that can be found on the Sleep Disorders Hub. I hope you'll check out the other 2 activities in the series that address the impact of obstructive sleep apnea related to excessive daytime sleepiness on quality of life and strategies to individualize treatment planning for patients with obstructive sleep apnea. The Sleep Disorders Hub has these activities and many others on obstructive apnea, excessive daytime sleepiness, narcolepsy, idiopathic hypersomnia, and more. So I would encourage our audience to visit the Sleep Disorders Hub for additional information, clinical guidelines, resources, and patient education about sleep disorders. So to receive CME CE credit for this activity, participants must complete the post-test and evaluation online. Participants will be able to download and print their certificate immediately upon completion. So Russell, thank you again for joining me today. I really appreciate it.
It's been my pleasure, Rick, and it's always nice to speak with you.
Yeah, and I would like to thank you, our audience, for joining us. Be safe and take care of yourselves so you can provide the best care for your patients.